Ryan Stanton here with ACEP Frontline, and today joined by Dr. David Carlberg. We're actually out in Seattle, so we can actually get some face-to-face. What you can't see right now is us overlooking the beautifully dreary Seattle skyline. So very nice area here, and appreciate you being willing to join us today. We have a topic today on eosinophilic esophagitis and some of that impact in emergency medicine. And so first and foremost, give us a little background on yourself.
Yeah, I'm one of the APDs and the academic vice chair at Georgetown Emergency Medicine, trained at UVA, and get to do some great work on this topic through some talks at ACEP, some talks at AEM, and so it's great. Thank you for the opportunity.
Yeah, so fantastic. Give us a little breakdown initially. Just let's start from the beginning on food bolus impactions and the current kind of state of affairs of management in the emergency department.
Right, I think we've all had that feeling, right? You take a bite of steak and it's too much and it feels like it hangs up. But when that doesn't go all the way down, that's a food impaction, right? So the complete impaction that you can get, it's more common in men than women. And if it hangs up and doesn't move down, that should be cleared within 6 hours if it's a full impaction. And if it's a partial impaction, you've got 24 hours. And then a lot of folks get them and it sticks there for half an hour, 2 hours before they come in for care. And so a lot of folks can find ways to kind of mitigate this if they have food hang up too much. But it becomes an emergency medicine disease when somebody comes in, and sometimes it clears on its own, and sometimes we can do medications, and sometimes they need a GI to do an endoscopy.
Is there, kind of jumping into this, is there a physiologic reason other than men eat like Neanderthals that men are more commonly impacted than women? And segue from that is there a reason why the timing for clearance is so important in terms of risk of complications?
Is there a reason why men have it more commonly than women? My very poor man's understanding is the eating more steak and meat and chewing less is my very poor man's understanding of why. But the longer the impaction is there, there's risk for things like probably pressure necrosis, aspiration, and then it's just so darn uncomfortable also. We've all seen them, right? The patient who has the full impaction and they just look terrible. If it was me, 2 hours would be my preferred as opposed to 6 hours.
So let's dive into the eosinophilic esophagitis. We do know that this is something and the rings and strictures do tend to be a little bit more common in men, not to negate the way we eat, which my wife reminds me of all the time. How does the EoE or eosinophilic esophagitis, say that 3 times fast, how does the EoE relate to those food impactions?
Well, when there's a structural cause, which is 80% of the time, EoE is the most common cause underlying it, as opposed to the strictures, as opposed to the esophageal webs. So EoE is going to be the most common thing causing it, with probably some decreased esophageal motility related to that, and the injury from the EoE.
What is the big risk factors that we see with EoE or with these impactions? We talk about some of the things that trigger the eosinophilic response in the human body. What are some of the things that are going to contribute to that?
Yeah, I think of those atopic folks, right? Asthma, allergies, those type of things are going to be certainly risk factors for EoE.
The incidence of eosinophilic esophagitis, it's about 1 in 2,000 people, but the numbers tend to be rising. Do we feel like that this is actually something that is increasing in incidence, or is it we're just increasing in our ability to detect it? And do you feel that, the numbers we know are just the tip of the iceberg of those that potentially actually have it?
I would probably think so. I would think that it goes fairly significantly underdosed, because a lot of folks have strategies that they use. If they do feel food hanging up, they'll incorporate into their everyday life. But honestly, since there are treatments out there, and since gastroenterology kind of owns this disease, getting folks to care will help us diagnose it better and hopefully manage it better and decrease disease burden, big picture.
A lot of people probably have done some adaptive behaviors, things that they do to deal with this without a diagnosis. People just understand, as you mentioned, you understand you get half a pound of lamb chop stuck in your goose, and so you learn that you're going to eat slower, you're going to chew more, you're going to take more time changing the way you eat. So may never actually even pursue the diagnosis itself, but there is an acronym that is used called IMPACT that talks about some of the common adaptive behaviors and traits. So talk about the IMPACT acronym and what it means for EoE.
Yeah, so the IMPACT acronym, it's imbibe, so folks will take liquids with meals. They'll modify their eating habits, smaller meals, right, avoiding foods possibly. The P is prolonged, so eating really slowly. A is avoidance, so avoiding food, avoiding social situations during meals, because you don't want to do this in front of a crowd, right? This is not something that you want to happen at the office holiday party. So kind of avoidance. Chewing, like make sure to chew really aggressively, or the T is turning away from food. And so folks will incorporate these into their daily lives, which mitigates the disease, but it doesn't fix the problem.
And like most disease processes, the more we put it off, the more risk of potential complications that take place. So why is this diagnosis of eosinophilic esophagitis and getting the appropriate treatment so important?
Because there's a variety of different treatments, and so kind of without making the diagnosis, you can't go towards kind of those specific treatments. Things like PPIs, things like steroids, things like other anti-inflammatories can help alleviate the symptoms and kind of make things better. But you won't get to that without diagnosis. And so kind of if you're having these symptoms, or for patients having the esophageal food impactions, getting them to the follow-up and the endoscopy that they need so they can take biopsies and things along those lines is going to be a key, because if there is an underlying process, it's important for folks to kind of find that out. And there was a study, I'm trying to remember the exact numbers, but over the course of a year after a visit for an esophageal impaction, 55% of patients don't get the follow-up that they need.
And that's an important opportunity for us in emergency medicine, because you mentioned the upper endoscopy, the biopsies, getting the diagnosis, those types of things. But just like anything else, healthcare, people feel better. They may not necessarily follow up. So what are some things we can do for messaging to these patients to say, I'm going to refer you to GI and you actually need to do it?
Especially for that patient that clears spontaneously in the ED, right? The patient that we give meds to or that clears in your waiting room, they need to get the message that they need to have GI follow-up, because there's usually some sort of structural issue going on, and that this could continue happening and this could get worse if they don't get that follow-up. And even more importantly, they could get better if they do get that follow-up. And so that's, I think, one of our keys is, especially in that category of folks that don't see a gastroenterologist in the ED, that they need the follow-up. But also, if it's 1 a.m, right, and the patient just woke up from a sedation for an endoscopy, they might not remember the GI physician that they saw. And so kind of highlighting to them, like, even though the problem is fixed, or the problem is temporized maybe even, that the follow-up is going to be key, even if you did see a gastroenterologist, because the thing that they care about most at that 1 a.m. time frame, the gastroenterologist, is let's fix the immediate problem. And they may not be focused on, hey, what are the underlying causes? So the follow-up is vital.
So let's chat a little bit about the treatment. I assume that it's just like anything, immune response, such as my allergies, my seasonal allergies, my atopic dermatitis, all that good stuff, that we're not looking typically, there's not a curable, but talk about some of the management and mitigation of EoE and the symptoms.
Yeah, so management, I think, frequently starts with things like PPIs, and then can expand. There's steroids that are considered, or other anti-inflammatories that can help alleviate symptoms that patients have.
All right, so we're in the ED right now, and let's just say we suspect EoE or something that's going on within that realm, what should we do? Like if we suspect it, have that patient come in with us in the emergency department?
Kind of really the keys are going to be follow-up. And a lot of emergency departments now have patient navigators, have social workers who can get follow-up, have different pathways to get folks in so that they don't have to wait 6 months to see a gastroenterologist. So I think if you have that pathway, please explore it. I think in terms of starting a patient on a PPI in the ED, I would actually suggest against it because they prefer that the endoscopy where they take the biopsies is done without PPIs on board because theoretically PPIs could mask some of what they need to see on biopsy. And so it's my understanding is it's a PPI-free period for around 3 weeks pre-endoscopy. So I wouldn't start that empirically in the ED.
Oh, that's good information because I think a lot of times we do try to help with symptoms in the management in the emergency department. So that's really good information. A lot of people, you mentioned the impact and the things that people do to temporize, home remedies, all those types of things. Of course, now it seems to be getting more rampant with AI and technology of everybody's got 1,000 ways to treat everything that doesn't have to do with evidence-based medicine. Why do some of these home remedies and self-management not a great plan, kind of encouraging patients against it and following up with GI?
Well, you know, in the short term, the self-management will help them get through until they see GI. So I wouldn't necessarily say don't do those impact things until follow-up because you don't want to get another food bolus and end up in the ED. But that being said, that's not going to fix the problem, right? And all those mitigation activities that you do, they're life-limiting, right? Avoiding social situations because of this isn't good for our patients. And so, you know, just highlighting to them the importance of following up with gastroenterology, and then of course, like good return precautions, right? This could happen again. Please come back if things are moving in the wrong direction.
Yeah, don't wait. I mean, it's one of those things, don't sit at home. I mean, I've noticed most that have a full impaction don't sit around that much. But now ACEP has worked on a smart phrase associated with the food impactions and EoE. Can you kind of hit on that a little bit and the kind of information that may be within there that we are kind of passing on, not only for us as the physicians to understand, but also for our patients to follow up, because no matter how well you talk about it in the emergency department, understanding that a patient only takes in about 10% of what you say, and the opportunity that they, you know, can actually have some stuff to read, some reading materials when they get home to kind of follow up.
I think an important part of it is highlighting that this might be EoE, right? That EoE is the most common cause when there's a structural cause, and there's a structural cause 80% of the time. And so that there might be something going on other than just this is a problem that you have to deal with. So they get that follow-up. And things that might trigger you as the emergency physician would be that history of the asthma, the hay fever, if you end up getting that history of, yeah, things hang up all the time, I usually drink some water and it gets better, and I really kind of chew everything for forever and ever. Highlighting to the patient that really might be EoE. And so the follow-up aspect is going to be so absolutely vital because this isn't a diagnosis that I'm going to make. I might suspect it. I might even suggest to the patients they may have it depending on the history that goes with it. But I'm not going to make the diagnosis. And so again, getting folks plugged in is really one of the most vital parts, and highlighting in the beginning of the smart phrase kind of what is a food impaction and what is EoE and what are the kind of associated symptoms that you may have in your life that you might not associate with, right? I don't know that I would associate my food impaction with my asthma. I don't know that I would associate my food impaction with my runny nose in the spring. But those actually might really be associated, and sparking that light bulb or turning on that light bulb in our own minds as emergency physicians and in our patients' minds.
Yeah, it runs through, as you mentioned, kind of what it is, what it's kind of related to, some of the medication management, the follow-up, caring for yourself at home, and then, of course, the things to look out for. There is something you can pass along from a quiz that's from the American Gastroenterological Association called eoepatients.gastro.org/quiz. So eoepatients.gastro.org/quiz. that allows the patients to kind of take a dive into some of the symptoms and maybe trigger them a little bit more to say, hey, is this something I have? But really for us in the emergency department, it is about providing the information and getting that follow-up care, encouraging them strongly to follow up with the GI specialist to get that upper endoscopy, especially if they've never done it before. Any closing thoughts as we wrap up today with regard to EoE and our role as emergency physicians?
I think recognition about the possibility. Like until I got kind of a deeper dive into the work on this topic, I didn't kind of necessarily realize how much EoE is associated with the esophageal food impactions. And so because of that, kind of that follow-up, right? Because frequently in the ER in the ED, we'll tell folks, oh, follow up for this, follow up for that. Mm-hmm. But there's a very specific reason why. And I think if we remember that reason why, we're going to be more likely to suggest that to our patients as opposed to more of the kind of CYA, follow up with gastroenterology. No, we can actually make a difference in folks' lives by establishing that follow-up and by kind of setting the wheels in motion to a possible diagnosis.
All right, talking with Dr. David Carlberg about eosinophilic esophagitis, EoE, as well as Smart Phrase and our impact in the emergency department. How can folks get in touch with you if they have any further questions?
Yeah, best way is my work email. It's david.carlberg, CARLBERG, @medstar.net.
And a reminder that there is a one-pager on the EoE website for the American College of Gastroenterology, the ACG. There's also a lot of other resources that are out there that you can do, but also checking out on the ACEP website the smart phrases that you can plug into your EMR to help provide that information at discharge. So thank you so much for joining us.
Absolutely. Thank you for the opportunity.
And as for me, you can contact me at rstanton@acep.org, rstanton@acep.org. A reminder, with the podcast, we are consolidating, transitioning to a new platform and source. So depending on where you get the podcast, if you make sure that you are subscribed on your favorite player to make sure you are successful with the transition. We're expanding the Frontline podcast network, providing more information, more resources, and more sources, viewpoints from the American College of Emergency Physicians, as well as emergency physicians from around the country and around the world. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all alone. Da, da, da.